Hi, today's topic is COPD, and today we are going to start a little bit differently. So, how the question will come in the exam? So, question will say that there is a 40-year-old or 50-year-old chronic smoker who have a history of 20 pack years, presents with cough, sputum, which is copious for last 2 to 3 months, and breathlessness after walking 100 meter. They will ask what is the diagnosis, tell MMRC grade, how will you manage the patient? We will come to this question a little bit late. First, we'll understand and then try to solve this question. So, what is COPD? COPD is a slowly progressive airflow obstructive disease that is not reversible. And the full form is chronic obstructive pulmonary disease. So, obstructive pulmonary disease definition. Chronic obstructive pulmonary disease. It is not reversible. Why we are saying it's not reversible? Because in asthma we have learned that if we give bronchodilators, then after giving bronchodilators there will be a change in FEV1 by more than 12%. Asthma is reversible after giving bronchodilators, but COPD is not. Now what is etiology? Most important one is alpha 1 antitrypsin deficiency, which is a genetic factor. Then smoking, recurrent infections, and occupational exposure. Now pathogenesis. Now, previously we used to say that there are two different entities, emphysema and chronic bronchitis, but now we consider COPD as a spectrum where there are two ends, emphysema and chronic bronchitis, and both of them exist in a patient, but we say that a person is having a COPD which is predominantly emphysematous or predominantly chronic bronchitis. So, what is emphysema? It is an irreversible damage to alveolar sac. So, so let's say this is one alveoli and this is another alveoli. There will be damage to their walls. When there will be a damage to their walls, then there will be a bulla formation. This will be a bulla, and not just two or three. There will be a lot of alveoli. And when this bulla will burst off, then there will be pneumothorax, which is a complication of this disease. So why there is a irreversible damage to alveolar sac? Because there is either increase in elastase activity, elastase which will damage the wall, or there is due to increased smoking, or there is decrease in anti-elastase activity due to antitrypsin deficiency. So either increase in elastase activity or decrease in anti-elastase activity, which will cause irreversible damage to alveolar sac, which will cause formation of bulla and then pneumothorax, which is a complication. If it's burst out, if bulla burst out. Then in chronic bronchitis, it is cough production for at least 3 months for 2 consecutive years. Why there will be cough production? Because there is increase in number of goblet cells due to inflammation. Due to inflammation. So inflammation and infection causes enlargement and increase in number of goblet cells. This is pathogenesis. Now we'll go to clinical feature. Now in the clinical feature, first thing which I want to say is that there will be no clubbing. Because the moment there is clubbing, then we have to suspect lung carcinoma. So no clubbing. Then smoking history, patient will say that he have smoking of 10 to 20 pack per year. On inspection, he will have barrel-shaped chest because of hyperinflation. Now symptoms. Now there are only three symptoms: cough, breathlessness, and sputum production. If there is prominent cough, then it is more of chronic bronchitis end. And if there is more breathlessness, then it is be more in emphysema. Sputum production scanty in emphysema. This we will call as smoker's cough, which is scanty. And in copious sputum is in chronic bronchitis because we know that goblet cells will be more, which will cause more mucus production and more copious sputum cough. Okay. Now there we used to have this term blue bloater and pink puffer. What is pink puffer? Now in emphysema, due to nicotine and due to tobacco effect, there will be polycythemia. Hemoglobin will be high, like their hemoglobin levels will be 18 to 20, which is not good. In Indian conditions, it can't be possible like someone is having 18 hemoglobin. So their hands will be pink because of polycythemia, and their weight will be less. And in chronic bronchitis, they will have cyanosis because of methemoglobin, and their weight will be high. So bloater, weight high, puffer, weight less, pink, polycythemia, blue, cyanosis. This is clinical feature. And clinical feature, we need to understand the MMRC grading of dyspnea. Dyspnea means breathlessness. So simple, grade 0, breathlessness only on strenuous exercise, which is normal. Like we also get breathlessness on exercise. 1, breathlessness on walking incline. 2, walk slower than peers. So for example, husband and wife is walking, husband is a smoker, his wife can walk faster than him. That is because his wife, and we are assuming husband and wife of same age, then walks slower than peers, then grade 2. Grade 3, walks 100 meter, then rest, and he have to catch breath. And grade 4, he can't even leave house. He can't even leave house. That much breathlessness will be there. Now, investigation. Most important investigation is FEV1 by FVC will be less than 0.7. Chest X-ray will show hyperinflation of lungs because there will be increase in reserved volume, increase in FVC, and so overall increase because there will be dead space increase, like there will be less ventilation, and DLCO will decrease. DLCO will decrease. CT on chest X-ray done. CT will show bulla. As I say, bulla, how it forms. Two alveoli walls will get damaged. They will coalesce and they will form bulla. In CBC, hemoglobin will increase. As I said, polycythemia, and genetic test might reveal alpha-1 antitrypsin deficiency, which is due to a gene defect. The gene is known as SERPINA gene. Hmm, SERPINA gene. Now treatment. Treatment will completely based on GOLD ABE assessment tool. Now this I have to explain properly. Okay, GOLD grading. GOLD grading. So all of them will have FEV1 by FVC. Okay. Stage 1, FEV1 less than 80% of predicted value. Like if someone's FEV1 is like 3 liter or 4 liter, it is less than 80%. Then stage 1, 79 to 50%, stage 2. 49 to 30%, stage 3. Less than 30%, stage 4. This is gold grading. It comes in exam for 3 marks. And exacerbation history. Now this is important. So if someone is having more than more than two exacerbation means he had 2 episodes of uh, breathlessness, like very bad breathlessness. Then or he had more than 1 hospitalization, then he will be in group E. And if someone had 0 to 1 exacerbation and his MMRC is 0 to 1 or MMRC is 2, as MMRC is already explained, so he will be either in group A or group B. Now what is this group A and group B? So if someone is in group A, he only needs to take LABA. One example, indacaterol. Here we are not giving formoterol, salmeterol, we are giving indacaterol. Group B will have added LAMA. LAMA you can give tiotropium. And in group E, we can give ICS, inhaled corticosteroids such as budesonide. What are the other steps? He have to stop smoking. What we can give? We can give nicotine buccal spray or nicotine chewing gum. Bulectomy by thoracoscopic surgery, one can do bulectomy. Why we are doing this? Because if this bulla ruptures, then he can have sudden pneumothorax formation. Lung physiotherapy, and this is a very additional point one not need to remember. But if the IgE values are less than 300, then we won't give inhaled corticosteroids. We will give either dupilumab or roflumilast plus azithromycin. This is not a necessary point. If you forget also, it's fine. So we have talked about all the points. Now we will talk about complication. There are only three complications to remember. Core pulmonale. This is the most important complication. This is right ventricular failure due to right ventricular failure due to lung disease. So that is core pulmonale. Then respiratory failure, pneumothorax. Pneumothorax already told, bulla formation. Differentials, asthma, TB, and interstitial lung disease. Now we will try to solve the question again. So, chronic smoker with history of 20 pack years. So definitely COPD. Patients with cough, sputum which is copious for last 2 to 3 months. So it means this is in the chronic bronchitis end of the spectrum. Okay, and breathlessness after walking 100 meters. That is MMRC MMRC grade 3. How will you manage the patient? So the MMRC grade 3 it is. So it will be, but they have not mentioned any episodes of exacerbation. So we can say that we can give group B, group B drug. What is group B drug? LABA plus LAMA. LABA, indacaterol, and LAMA, tiotropium. So that's all for the topic of COPD. Hope you like the video and subscribe. Thank you.